Hi, this is Robert Adoran, and we're going to discuss tamponade and pericardiocentesis. This talk is going to be broken down into diagnosis and management. We're going to discuss step-by-step ways of performing a pericardiocentesis. We'll look at some unique and interesting cases together. We will discuss complications, how to triage tamponade cases, and we will also look at special situations. It is important for you to know some fundamentals. In tamponade, intrapericardial pressure begins to match and then exceed intracardiac pressure. And ventricular filling becomes impaired during diastole. And because of the impaired RV filling, the wide descent in the right atrial pressure waveform becomes blunted. Pulsus paradoxus is, of course, an exaggeration of ventricular interdependence, and diastolic pressures equalize, and there becomes a decline in LV filling and in stroke volume, and ultimately shock and death can ensue. The definitive treatment for pericardial tamponade, of course, is drainage of the excess pericardial fluid. Probably the first blind pericardiocentesis was performed in 1840 by Franz Schuh, and this was in a 24-year-old with a mediastinal tumor. A trocar was inserted in the intercostal spaces to drain the effusion. Naturally, part of your workup will include identifying the cause of the tamponade. There are a number of pericardial diseases and factors that can lead to tamponade, the most likely being neoplasia, certain infections, iatrogenic causes including post-traumatic, post-cardiac surgery, and renal failure, to name a few. There are a number of classic relative contraindications to pericardiocentesis. In coagulopathies and in thrombocytopenia, the bleed risk is elevated. In the case of myocardial rupture, further drainage may worsen or propagate the bleeding. In the case of thoracic aortic dissections, treating the tamponade may raise cardiac index and further propagate bleeding or thrombus. And in the case of severe pulmonary hypertension, this is a situation where the RV has significant afterload. If the tamponade is drained, the RV may dilate and be met with further afterload and also interdependence, collapsing the LV and leading overall to hemodynamic collapse. Now here are my suggested steps to conducting a pericardiocentesis. You may decide to add or alter this based on your particular preferences. But at first, the patient should be supported with fluids, pressors, and avoid intubation if possible. If the tamponade is being caused by an iatrogenic cause, such as due to a ruptured coronary artery, then do not consider giving protamine until after you've drained the tamponade, because otherwise the effusion may become solidified and you may develop thrombus in your drainage tubing and fail to drain it. Use echo to select your best and safest approach. Use local anesthetic generously and consider adding some bicarbonate to reduce the discomfort. Utilize a micropuncture needle and advance it carefully, guided by echocardiogram, and aspirate as you go. In preference, use a nitinol wire so that it is more sturdy and less likely to become trapped. Once your microcatheter is in place, you can utilize it to measure pressures and also perform a bubble study to ensure that you are in the right place. Advance all your sheaths or dilators under fluoroscopy Once you place an 035 dilator in, escalate to a stiff 035 wire and advance your equipment under fluoroscopy to ensure it tracks correctly. Don't be afraid of utilizing multiple fluoroscopic views. Insert your pigtail, and once your pigtail's in place, remeasure your intrapericardial pressures and start draining. You can then, after draining the effusion, repeat the echocardiogram to ensure that it has been drained, measure a final pressure, and suture your drain in place. A chest x-ray is finally recommended. This is a very interesting retrospective study out of Belgium that looked at the etiology and outcome of patients who underwent pericardiocentesis. This was a retrospective observational design, and the patients were effectively followed for 10 years. Overall, the survival out to 10 years for a patient with a pericardiocentesis was not very good, as you can see on the left. The authors also divided the patients into etiologic category, and you can see that in the yellow line, the group with malignancy fared the worst, as you might expect. The patients with iatrogenic effusions, shown in the green line, did relatively better, and interestingly, in the blue, the patients with an idiopathic effusion did have fairly poor outcomes over 10 years as well. But bear in mind, this is a retrospective analysis. Pericardial effusions come in different sizes, and these representative echo images show them to you from trivial all the way to large. This graph plots intrapericardial volume on the horizontal axis against intrapericardial pressure in the vertical. And you can see that if the volume rises quickly, it is likely to overcome atrial pressures more quickly by reaching a certain threshold, after which tamponade can ensue. If the volume, as the right-sided curve shows, raises slowly, there is more time for the pericardial sac to enlarge and to absorb the increase in volume, and therefore the pressure in the pericardial segment will not rise as quickly, and you may not see tamponade for quite some time. This diagram shows ventricular interdependence. There is a fixed space within the heart where the RV and the LV are. With inspiration, there is increased venous return. The RV enlarges and presses relatively into the left ventricle, and with expiration, this occurs in reverse. With pulsus paradoxus, in tamponade, this occurs in a more exaggerated fashion. These CT scans demonstrate to you where the heart and the pericardium sits with respect to the rib cage. In the short axis view, you can see that you're subxiphoid and under the costal areas, and in the view on the right, you can see how a subxiphoid approach might be utilized to also gain access to the pericardium, although caution has to be taken with the liver and other GI structures. These anatomic dissections are very helpful because, as you can see in the top left, the pericardial space includes significant portions of the ascending aorta and the superior vena cava. So any bleeding associated with them, for instance, as may occur in a lead extraction procedure or in a dissecting aortic aneurysm, could lead to bleeding into the pericardial space. And the images on the right show where the lungs can be with respect to the heart, and therefore an apical approach pericardiocentesis does run the risk of puncturing lung tissue or pleural tissue. Now, some of what I show you in this talk will not only occur in real life, but is also well represented in board-style questions. Here is one such example. On the right, on the top, you can see characteristic right atrial pressure tracings. With tamponade, early on, there may actually be a slight elevation of RA pressure, but importantly, and classically, loss of the rapid Y descent. This, of course, is due to impaired filling of the right ventricle, based on a classic publication in the 1980s. Right atrial collapse more than 1/3 of the cardiac cycle is sensitive and specific for clinical cardiac tamponade. These pressure tracings are a great way to appreciate what happens in the heart and the chambers as an effusion develops. You can see that at the bottom, the pericardial pressure is currently low. There is no significant effusion. A little higher than that is atrial pressure, and higher than that still the ventricular pressure waveform. In ventricular diastole, atrial pressures are higher than ventricular diastolic pressure, and therefore there is forward flow of blood from the atrium into the ventricle. Now, as a pericardial effusion forms here, you'll notice that the pericardial pressure has now come up relatively, and the gradient between the atrium and the ventricle is less, and therefore there will be less flow, less emptying into the ventricle. With further effusion forming, now the pericardial pressure has come up enough to essentially match atrial pressure. And now you can see that there is a very minimal gradient between atrial and ventricular pressures, and as a result, there is less filling into the ventricle, and actually the stroke volume is less. Notice that the ventricular pressure has now gone down at peak. Now there's a whole world of trouble as pericardial pressures have exceeded atrial pressures. The atria are collapsed. There is really very little forward flow from the atria into the ventricles, and ventricular output has dropped even further. This is going to lead to hemodynamic collapse. Echocardiography is important in the evaluation of possible tamponade, and some of the findings that you would expect include right atrial diastolic collapse that you can see on the top left, right ventricular diastolic collapse on the top right, a non-collapsible IVC in the bottom left, and increased variability in flow across the mitral and tricuspid valves. Here are tracings obtained using a Swan-Ganz catheter in a patient who is in tamponade and has been intubated. You can appreciate that, as shown here, the RV, PA, and LV tracings demonstrate that diastolic values have become very similar to each other, which supports the concept of equalization of pressures. In this particular patient, we measured pericardial pressures, which are shown on top. After the effusion was drained, pericardial pressures were significantly lower as expected. The values did not reach zero, however, probably because the patient was mechanically ventilated. I'd like to show you a number of interesting cases because they will all contain important teaching points. Here's a case published where a patient with a prior history of bypass undergoes an intervention to a chronic total occlusion of the circumflex artery. After the procedure, the patient develops hematoma across from both atria. It is not circumferential because in many cases post-bypass patients are more prone to loculations and having loculated effusions. You can see on a CT scan on the left that the patient has effusions and they appear to be focused more around the atria, and in fact in this case CT guidance was obtained to drain the effusion, and the drain is shown on the image on the right. If you are an interventional cardiologist, you may on occasion have complications such as coronary perforations with angioplasty and stenting. These can cause a pericardial effusion as expected, and in particular, as shown in this study, if you have an Ellis class 3 coronary perforation, in this series there was a 28% chance that management included performing a pericardiocentesis. Performance of a bubble study is very helpful to ensure that you are in the correct place. On the left, bubbles have been injected through a micropuncture sheath, and they appear within the pericardial space as desired. On the right, however, the bubbles are seen in the ventricles that suggests that the drain is not in the correct place. It is helpful to know what an effusion may look like on fluoroscopy. In the case of a coronary perforation, the contrast can travel from the coronary artery out into the pericardial space and opacify circumferentially around the heart, as you see here. You can again here on the left see the pericardial effusion with opacification around the heart. If echocardiography is not available for whatever reason and tamponade is suspected, then you can utilize fluoroscopy to attempt to access the effusion and then inject contrast through the micropuncture needle and watch on fluoroscopy to see if the contrast extends into the pericardial space. When you have advanced your wire into the pericardium, you would expect to see a loop around the pericardial space, as you may see in the image here. Needle pericardiocentesis can have complication rates typically less than 5%. In a number of series, these complications included puncturing the ventricles, lacerating organs, including the liver, causing a pneumothorax, or creating cardiac arrhythmias. In these series, nearly all these complications occurred in emergency situations. Here is a case that was published. It is a 45-year-old woman with acute myelogenous leukemia who was admitted with pericardial tamponade. The tamponade was drained, 500 mils removed, and 6 hours later the patient developed shock and pulmonary edema. This case was published and it's been observed in a number of other series as well, which is acute pulmonary edema following pericardiocentesis. In this case, the patient was treated with inotropes, intubated. The LVEF on repeat echo was found to be down to 30%. It was normal before. Troponins were only marginally elevated, and on cardiac MRI, there was no evidence of ischemia or inflammation. And in fact, the LV ejection fraction recovered in 3 days' time. This case highlights something that you may on occasion come across, the so-called pericardial decompression syndrome, and in this publication in 2021, a number of small series and case reports were evaluated. First of all, this syndrome is rare but it involves a paradoxical deterioration or LV dysfunction after a pericardiocentesis. In most cases, LV hypokinesis was occurring. This may be associated with drainage of larger volumes and faster drainage of effusions. The majority of patients survived this insult. Though it is not clear why this occurs, there have been some ideas put forward. One is that with intrapericardial pressure in tamponade, coronary blood flow is reduced. With rapid drainage of the effusion and the drop of surrounding pressures, coronary perfusion can quickly rise and expose the myocardium to reperfusion injury. Another is that perhaps there's a sympathetic overdrive during tamponade, and that masks ventricular dysfunction by the increased inotropy that occurs, but once the tamponade is drained, it is unmasked and there's LV dysfunction. And finally, perhaps that the sudden increase in wall stress after pericardiocentesis may lead to stunning of the myocardium. Here's an interesting case report that was published recently where during a pericardiocentesis attempt, the drain was accidentally placed within the right ventricle. The operators first placed a second stent correctly into the pericardial space to drain the tamponade, and then utilized an 8 French angioseal guided by imaging to seal the right ventricular perforation. Here's something that can occur quite often: pain or pleuritic pain after draining an effusion. What do you do in these situations? Well, certainly you can place patients on non-steroidals or even colchicine in the appropriate clinical setting. But in the acute setting, it is not unreasonable to inject 10 mils of 1% lidocaine into the pericardial space through your drain to help with the immediate discomfort that may occur. This case highlights the importance of safe access and echo guidance. In this case, the liver was lacerated and a drain was placed effectively through it during a pericardiocentesis, and it actually required surgical repair. On occasion, after successful drainage of tamponade, the patient may actually develop heart block or a complete collapse, which results in the need for brief CPR or pacing. This has been described in the literature, and it may be a result of a loss of adrenergic tone and an overtaking of a vagal tone after the tamponade has been drained. These are very useful tips and nuances that you should be aware of in the setting of effusions in tamponade. You should be aware that pulsus paradoxus can be missing in certain situations. In the case of positive pressure ventilation, the fall in intrathoracic pressure is prevented, and so pulses can be missing. In the case of severe aortic regurgitation, underfilling of the left ventricle during inspiration is not allowed. An atrial septal defect will equalize right and left atrial pressures and prevent the differential right and left ventricular filling that can occur with inspiration normally. Severe left ventricular hypertrophy may not permit the inspiratory shift of the ventricular septum from the right to the left. In the case of a severe dysfunctional dilated left ventricle with elevated end diastolic pressures, they may not be subject to pulsus paradoxus because the LV does not get underfilled or compressed. Severe intravascular volume depletion, be it due to hemorrhage, dialysis, or overuse of diuretics, can lead to marked hypotension and also make detection of pulsus paradoxus difficult or impossible. The presence of a plethoric IVC is notable and occurs in most pericardial effusions with pulses. It is sensitive for tamponade, but it lacks specificity, and it is less helpful if the patient is on a vent receiving positive pressure. You may not see RV free wall collapse in the cases of pulmonary hypertension or right ventricular hypertrophy. There are also important nuances that you need to know about with regards to intubation and ventilation. First, mechanical ventilation can reduce venous return by raising intrathoracic pressure. Mech ventilation can also reduce the inspiratory variation that you get across the valves. Mechanically ventilated patients with an effusion may show a plethoric IVC on echo just because of the positive pressure ventilation. And you will have all likely seen patients who collapse hemodynamically if you attempt to intubate them. So in the case of tamponade or suspected tamponade, consider utilizing agents that cause little systemic vasodilation and hypotension, such as ketamine and etomidate. In assessing a patient with an effusion, you've no doubt heard operators say, but it's been there for a long time, surely it can't be tamponade. But this is not always an accurate way of thinking about it. As we saw on the graph in the top right, even more chronic effusions can ultimately lead to the pericardial pressure superseding atrial pressures and leading to tamponade physiology. In one series, in patients with large idiopathic chronic pericardial effusions, 29% went on to develop tamponade. The timing varied greatly and was hard to predict. But it is important to note that even chronic effusions can lead to tamponade, and each patient should be evaluated on its own merits and clinical scenario. Testing the pericardial fluid is standard, but the diagnostic yield is typically less than 40%. Which one of these statements is false? Following cardiac surgery, A, pericardial effusions are common. B, pericardial effusions are typically large. C, pericardial effusions usually resolve within a month. And D, colchicine and NSAIDs do not work well. The one that is false is in fact B. D is in fact a correct statement. Colchicine and NSAIDs do not work well. The European Society of Cardiology has published a scoring and triage system in the evaluation of patients with a pericardial effusion. You can score the patient first using scores for potential etiology. You can see, for example, that malignant disease or tuberculosis would score 2 points for the patient. Then you could score based on features within the clinical presentation, and then score based on imaging findings. If the cumulative score is 6 or greater, then urgent pericardiocentesis is suggested according to their score. However, in the case of type A aortic dissection, ventricular free wall rupture, recent chest trauma, or iatrogenic etiology, then urgent surgical management is recommended. There are other scoring systems also available, and they have not necessarily been validated. So graduating fellows who go on to your new labs Ensure that there are pericardiocentesis kits available, that you have the means to perform micropuncture in a bubble study. Avoid intubating if you can in a potential tamponade case because of reasons we discussed. Use stiff nitinol wires for your procedure and have echo available in the cath lab and know where it is out of hours. Additional information is available on tamponade.org, an effort that has been led by some of our faculty. Thank you very much for your attention.